Thank you very much. It's my pleasure to join today, and I would like to thank the organizers for inviting me. I hope that you can see my slides well. James, can you?
I can.
You can, excellent. So again, thank you very much for inviting me. My name is Susanne Schneider. I'm a professor at the University of Munich and a consultant neurologist. And I was invited to speak about the natural history of MPAN. For those of you who are not familiar with that term, natural history refers to the progression of a disease process in an individual over time in the absence of treatment from the disease onset until either its resolution or the individual's death. And there are different types of natural history studies that can be performed. And one can distinguish between retrospective and prospective natural history studies. Retrospective studies are done when the evaluations have already occurred. And one of the problems is that these evaluations may be biased or variable. And so superior to that are prospective natural history studies, where evaluations are being done in a standardized manner and occur in the future. Another way to distinguish different types of natural history studies is with regards to cross-sectional studies versus longitudinal studies. And cross-sectional studies are being performed across a cohort during a specified limited time period. And in contrast to that, there are longitudinal studies where the assessments are done over time at different time points. I'm showing this, sorry, I think you can, let me just briefly, no, sorry, because I have something in, can you see it better now? The natural history is becoming more and more important, in particular for rare disorders, because this allows to understand the different stages of the illness, as well as the likelihood and rate of progression. It also allows to understand the effects of current treatment, usually with some background therapy, because patients are usually not untreated. And it also allows to understand the disease burden. Often, and for many diseases, natural history data are sparse because of the rarity of some of these disorders, and because there are only a handful of experts, and because there may be bias in reporting, and that only single aspects are being reported on, or only severe cases are being published in the literature. There is, however, importance to gain better understanding of the natural history of these diseases, because the FDA now wants this to be done. And if you have good natural history data, you can use certain trial designs which allow a smaller number of patients to be recruited. This is why, as I've just mentioned, the FDA now encourages to perform natural history studies in the context of drug development. And here's a paper from the FDA as a guidance for industry where they highlight this. And accordingly, we are now seeing more and more natural history studies being published in the literature for various rare disorders. Here are some examples. So we've seen this for muscular dystrophy, for some of the SMAs, and also for Krabbe disease, but this is only a short list of the many examples where we see natural history data come out now. And we have seen a very recent publication on natural history for PCAN from this Chinese group. But now let me turn to MPAN. And this was just a background really, and now let me turn to MPAN. As you know, the clinical phenotype of MPAN is very complex, and this is one of the earliest publications where you can see the different symptoms that these patients may develop over time. By now, more than 115 patients with MPAN have been described in the literature, and this is a recent paper from Ph.D. and his colleagues where they've summarized these 115 cases. In fact, since then, some other studies have come out, including one from Turkey and one from Russia, so it's a bit more than 115, but this is a good table that shows the different symptoms in these patients. To summarize, this study or this review article looked at 115 cases from 28 studies where the mean age of onset was around 11 years, but you can see there's a broad variability in the age of onset, which ranged from 3 to 36 years. And the most common neurological features which were reported include upper motor neuron signs, so that means spasticity, hyperreflexia in more than 80% of patients. Also movement disorders, including dystonia and Parkinsonism, both in about half of the patients, and then neuropathy with limb weakness and atrophy in about 40% of cases. I've already mentioned that there's a broad phenotypic variability in MPAN, and this is just to demonstrate this. There are some case reports including describing a phenotype of an ALS type of presentation, so juvenile amyotrophic lateral sclerosis. There may be cerebellar phenotypes. A spastic paraplegia type has been described, as well as the description of a Bear syndrome, which comes from the ophthalmological point of view. We have now also tried to shed some light on the natural history of MPAN, and the results I'm going to show now is based on the TIRCON cohort, which is a large cohort of NBIA patients from Europe and also the Middle East. And this includes 420 patients in the registry. The center of this is in Munich, and this is run by Thomas Klopstock. And we have now looked at the MPAN sub-cohort, and this was done by one of my fellows, Vasilina Yankova, who's really done a great job here. So as you can see here, we have identified 61 patients with MPAN. About half of them were female and half of them were male. And some of these, about more than half of them, had multiple data entries, which were entered every year or 2 years. And these are some epidemiological data. You can see that many of these patients were referred from Poland, and we're going to hear more from Marta, who is seeing these patients. There's also a substantial proportion from Germany and from Iran. In this cohort of more than 60 patients, the mean age of onset was 9 years, again with a broad range ranging from 3 to 20 years, and a mean age at diagnosis of 14 years, leaving a diagnostic delay of 5 years. We looked at the different symptoms that patients developed, and now you can see those by descending frequency. So on the top panel, you can see that gait abnormality and postural instability, as well as pyramidal involvement and dysarthria, as well as problems with vision were the most common ones. And the red bars show that these symptoms were present. And then on the lower part of this slide, you will find those which were less frequent, where the green bar is sort of shown. But I want to highlight that often we also see a blue column, which stands for that it's not known whether the symptom was present or not. And that shows us scientists or clinicians that we should really try and put a full description into our patient registries or in our case summaries, because otherwise the information is simply not available. There's also a slide on the psychiatric symptoms that these patients develop. About half of these patients did develop psychiatric features along the way, in particular emotional incontinence, anxiety, and apathy, as the most common manifestations. Here you can see the same information, but displayed in a different way, where the symptoms are shown by age and by disease duration. And really, you can see that the onset's about the age of 9, as I've already shown you. And then over time, in particular, in the subsequent 10 to 15 years, patients develop further symptoms in reflecting the progressive nature of the disease. You can see that for each of the symptoms, there are different black dots along the horizontal line, and that shows the phenotypic variability between patients. This is a comparison between symptoms of symptoms between MPAN and typical PCAN, and the picture on the left is what you've just seen, and the picture on the right is taken from the natural history study from the Chinese group in PCAN that I've pointed you at earlier on an earlier slide. And I've tried to sort of show that here on the left, at the age of 10, that's the usual age of onset in MPAN, whereas here in PCAN, it is much earlier, it's around the age of 3 or so. This is the comparison with regards to dystonia, which usually has its age of onset in MPAN around the age of 16, but tends to come on earlier in the PCAN cohort. And then likewise, speech problems develop around age 15 or so in the MPAN patients, whereas it is present earlier around age 7 in typical PCAN. But again, there's phenotypic variability between cases. In our cohort of MPAN patients, we looked at the severity of dystonia, and we had data available based on the Berry-Albright dystonia scale, the BAD scale. And that is a 5-point criterion-based ordinal scale for 8 body regions, each of them ranging from 0, which means no dystonia, to 4, which means severe dystonia, yielding a maximum score of 32. And this Berry-Albright dystonia scale was chosen for the TIRCON registry because it is one of the most widely used scales in intervention studies for children with dyskinetic cerebral palsy. Sorry. These are the data, so you can see the BAD score on the y-axis on the left and the years into the disease on the x-axis. The red dotted line on the top, the horizontal line, stands for the maximum score that you can achieve in theory, and the blue sort of blue line here is the average of all patients. And it really shows that there is a progression over time. And after 20 years, patients reach about 12 to 15 points on average. We looked into this further and subdivided in between arm dystonia and leg dystonia. Each of these can reach 8 points. So you can see that horizontal line. And you can see that the arm dystonia very much progresses over time and seems to further progress even after 20 years, whereas leg dystonia tends to surface after about 8 to 10 years of disease duration. We also looked at Parkinsonism, and we have data based on the UPDRS scale. UPDRS stands for Unified Parkinson's Disease Rating Scale, and is the most widely used scale to assess Parkinson's disease patients in PD clinics. The UPDRS consists of 4 different parts. Part 1 measures cognition, behavior, and mood. Part 2 measures activity of daily living and is a self-evaluation scale. And part 3 is the typical motor assessment, which we do in our Parkinson's clinics for our PD patients. And you can see the maximum scores in brackets behind it. There's also a 4th part, which measures treatment complications, mainly dyskinesia, which don't apply for patients with NBIA disorders. I've shown the different findings for the 3 scales. So on the left, the UPDRS part 1, which measures cognition, behavior, and mood. And again, you see the red dotted line, which stands for the maximum score that you can, or that is possible. And you can see that patients do have some problems with that, but reach on average only about 4 to 5 patients. So it does not seem to be a major problem, at least by the questions that are being looked at and on the UPDRS. Then there's the activity of daily living score. You can reach 52 points, and you can see that after 20 years, patients have an average of about 30 to around 30 points. And again, you can see the progression over time. And then there's part 3, which is the motor assessment, where you can reach 108 points. And again, you can see the progression over time until the disease duration of 20 years or so. And then we also looked at loss of independent ambulation in MPAN. And again, on the left is the MPAN cohort, and on the right, you see data from the Ph.D. paper published by Chang and colleagues from the Chinese cohort. We looked at different events when patients needed a stick as a walking aid, and that occurred on average after 5 years into disease. After 10 years, they needed a walking frame, and after 12 years, they needed a wheelchair. You can see these black dots in the horizontal, in the vertical line, which show again that there's a wide range of variability between patients. And you can compare this to the Ph.D. study, although they have a different way of presenting this. You can see the brown line where there's early onset and the black line, which stands for late onset. And this is a Kaplan-Meier curve of presentation. So every time someone reaches a different event, you will have a step going down. And they looked at the ability of, of the proportion of patients with ability of independent ambulation. So they looked at slightly different things, but still you can see that there's a progression over time, which is a similar finding as we have. And furthermore, we looked at the Schwab-England scale, and that is a scale that assesses the capabilities in the context of impaired mobility. The Schwab-England scale measures gives percentages. 100% means that someone is completely fit and independent, whereas decreasing numbers stand for a loss of independency. So 50% meaning someone is mostly dependent, and 0 means someone is fully dependent. And again, you can see here the findings over the years into the disease. And again, it's very clear that there's a progression over time where the average of patient loses their ability to of independence over time. And this really were the data from our TIRCON data set. And again, as I've mentioned, Vasilina Yankova has really spent a lot of time analyzing this, and Thomas Klopstock is leading this in the Munich Center, but there are so many other TIRCON consortium and partners, in particular the referring clinicians. Without them, this would not have been possible, in particular the group from Poland, of course, who has referred so many patients for this. So thank you very much to all those involved, and thank you again for inviting me.
Well, thank you for presenting. I wonder if would you be willing to take a couple of questions before we move on to the second presentation?
Sure. I mean, someone, Fatime is asking whether these have been published, and so no, this has not been published yet.
Okay.
We're writing up the manuscript, but we're waiting for some other data to be combined.
Oh, yes. Okay.
Mm-hmm. Can I have a question, Susanne?
Sure.
Thank you very much for your beautiful presentation. It is very important to have natural history, we've seen that the patient deteriorates during the time. And do you have? I don't know. I wasn't participating in TIRCON. Is that you have checked each patient year by year, and you can see that, for instance, it starts with dystonia at the age of 8, and then at age of 10, the dystonia is so severe he can't walk, and at age of 12, he's bedridden, for instance, or you have one time point entering for patients in different age.
Yes, thank you. So the TIRCON study sees patients on multiple occasions as often as they come. And so for some patients, they only show up once, and so we have only one time point. But then we have patients who have come multiple times every year or every 2 years or every 6 months. And then we do the same scales every time they come. So for these patients, we have longitudinal data. And as I showed on one of the earlier slides, this is we've included all the data that we have. And for some of them, we only have one time point, but there are also about more than half of them have more than one time point. So we have longitudinal data for these.
Okay. Again, thank you very much, Dr. Schneider. Dr. Skowronska, you ready to do your presentation?
Good evening, ladies and gentlemen. Thank you very much for your invitation. My name is Marta. I'm a neurologist, and I work in Warsaw, Poland, and I work mainly with MPAN patients, and I would like to present 2 studies that are ongoing in our department, 2 clinical studies about MPAN research. Here are my financial disclosures. I have received a financial grant from NBIA Polska. And the first study I would like to present was partly published in 2020. And we thought that MPAN patients who suffer from optic nerve atrophy and dementia are somehow similar to other group of diseases called mitochondrial diseases. C19 or 12 is a gene that encodes protein somehow connected to mitochondria. So we thought that maybe MPAN patients might suffer from heart disease like patients with mitochondrial diseases. About 30% of patients with mitochondrial diseases have heart disease. 10% of them experience minor adverse cardiovascular events. And the most common abnormalities which are seen in mitochondrial disease patients are cardiomyopathy and cardiac arrhythmias. So we have performed a study, which was, this table was published in a paper I showed previously. And with this table was slightly modified, and I will show you the modifications. First of all, we have examined 13 patients, 3 of them were females. As you can see, most of them were carrying our typical Polish mutation, which is delayed revision. But we also had some patients with other mutations. They were all adult patients with age ranging from 18 to 27. All of them, except one, suffered from optic nerve atrophy. All of them, once again, except one, suffered from neuropathy, which are typical for MPAN. And all of them had some kind of cognitive impairment or even dementia. What we have found in cardiac examination, first in echocardiography, that left ventricle ejection fraction was normal in all cases, starting from the younger ones and ending at the oldest patient, who was 27. But in 24 hours Holter ECG, we found some abnormalities with predominant tachycardia, and in 2 cases we found some cardiac arrhythmias. In one case it was sinus burst, nearly 3 seconds, lasting nearly 3 seconds, and in one case, this is the modification, because atrial fibrillation, paroxysmal atrial fibrillation, was found during this year examination. So in the paper, there was just predominant non-tachycardia in this case as well. If we would like to summarize our results, cardiomyopathy, which was typical for mitochondrial diseases and seen even if in echocardiography, was not found in our MPAN patients. All of them had left ventricle ejection fraction over 60%. Of course, we didn't perform more specific studies for cardiomyopathy, like magnetic resonance of the heart, but in cases of mitochondrial diseases, cardiomyopathy is seen even if in echocardiography. What we have found was that heart rate heart rate variability was lower than average, and heart rate variability depends on the interplay between parasympathetic and sympathetic nervous system. So we thought that maybe MPAN patients suffer from dysautonomia. And this year we have performed study on larger group because we have 26 MPAN patients. And we have examined all younger patients because age range was from 12 to 29. All of them had 24-hour ECG, but also we performed some more specific electrophysiological studies, like changes in heart rate during deep breathing and Valsalva maneuver, together with sympathetic skin response. And what we found was pathological results in electrophysiological study in all our cases, which confirmed dysautonomia in MPAN patients. So, in conclusions, we are preparing a paper about this study. Is about the conclusion. First conclusion is that MPAN patients suffer also from sympathetic and parasympathetic impairment. And this conclusion was also made in the paper that we recommend the standard cardiac workup in all MPAN patients because some cardiac arrhythmia might be found. And we found in two our cases, cardiac arrhythmias, first atrial fibrillation, second the sinus pulse. And both those patients are treated with additional treatment. The second study is ongoing, so I will share only a few our observations with you because we have no conclusions yet. We had an observation, clinical observation, that MPAN patients are somehow sensitive to starvation and intense physical activity. We didn't measure the intensity of physical activity and the duration of starvation. It was just a clinical observation. And both those states, I mean starvation and intense physical activity, causes neurological deterioration, which seems to be reversible after a meal or a rest. But we don't know whether it's fully reversible. It seems to be reversible, but maybe not. So we have designed a study where patients are treated with regular meals, inadequate caloric supply, and some other diet supplies. And we are hoping that this might prevent further deterioration of MPAN patients. We have only 3 months of observation because the study is ongoing, and we started in February, so we are now having the first time point and time and first observations. And I'm afraid they are not conclusive yet. The second time point is it will be after 6 months of this treatment. So I hope that during next conference I might present some more details about this study. I'm afraid that is all I have prepared for today. We do not have many clinical studies going on right now because of COVID, which stops us. My department is really coping with this. So thank you very much for your attention, and I think that the questions will be asked after all presentations. Thank you once again.
Dr. Schneider, you said you have another recorded presentation we can go to now?
Sure. I mean, if there are no questions from the audience, as it happens, I did a recording at a different meeting in the last fall, and we have that recorded. So if there's still time left and people are interested, we could stream that. It is about how to get ready for a treatment trial in MPAN. It's a more general overview as to what steps have to be done to get ready for a trial. And that's about 22 minutes. So we would have time to show that if people are interested.
A couple of questions have come in regarding anticipation of publication, when another cohort of patients might be recruited for the last study. Can we respond to those questions?
Marta, I believe it's for you. Your mic's still off.
Yes, Marta.
Yes, but could you repeat once again, please?
Yes, there are a couple of questions. One is when are natural history results going to be published? And
natural history is Susanne. Well, we are having some kind of longitudinal study also ongoing in Warsaw, but we are not ready for the publication yet.
And how about recruitment of other groups of patients? Is that still ongoing?
Well, I take care mostly of MPAN patients because they are adults or nearly adults, and the PKAN patients are with Professor Magda Krawczyk, which is also here and she takes care of PKANs because we have some PKANs also in Poland and BPANs. And well, they have started also this diet study. So maybe we will come up with some data later on, but the children have started just now, so we don't have any conclusions yet.
Well, thank you both for the continued work. We certainly look forward to hearing about this in subsequent meetings. It's very, very important to get more attention on MPAN. At this point, Dr. Schneider, do you want to proceed with the recorded other presentation?
Sure. Chris, can you help us? It's my pleasure to contribute. Again, thank you for inviting me. I will be talking about trial readiness and what do we need before a successful clinical trial in MPAN. Let me start by saying drug development is complicated. And there are various challenges and obstacles along the way. And during my talk in the next 20 to 25 minutes or so, I want to discuss a few of these, and that includes we need to understand the pathophysiology, we need to find a good drug candidate and identify and validate biomarkers. We need to find good clinical outcome measures. We need to improve our knowledge of the disease and the disease course. We need effective recruitment strategies. We need to choose an optimal trial design. We have to face various regulatory aspects, and we need funding to do all this. So let's have a closer look. What's our challenge? Challenge number one, we need to understand disease pathophysiology. Thankfully, there are a lot of things we already know. And we've heard about this today, but there are still a lot of things that we don't know. And this includes, how do mutations lead to neurodegeneration? Why does iron accumulate? What is the role of iron? And there are many other questions where we still don't know the answers. So I think one of the things we need to do in the future is to learn more about this. And I know that there's a lot of effort being made, and there are a lot of efficient people here today and out there, and that's good. Challenge number 2, we need a good drug candidate. There's a formal drug discovery process, and you can see an icon on the right, and that includes target validation, assay development, high throughput screening, and this may also identify a drug which is already on the market in the sense of repurposing, where we can find a hit to lead, so an optimal drug candidate which may be most potential to have benefit, which will then be optimized. We have to do various preclinical studies and clinical studies in this process, and that not only includes the biochemical aspects as such, but also various regulatory things when it's about facing standard manufacturing procedures for the formulation and looking at the guidelines on process validation for finishing products when we apply for approval to regulatory bodies. You are all familiar with the different clinical stages of drug studies, and that includes phase 1 to 4, where we look at safety and dosing, first in healthy volunteers. We then study our drug in a small number of patients, followed by a larger number of patients with the targeted disease. We need to identify and validate biomarkers, and biomarkers are objective indicators of medical states which can be observed from outside the patient. Biomarkers should reflect target engagement and response to treatment. They must be accurate, sensitive, reliable, and reproducible. They may be biospecimen based, so they may be markers in blood, urine, CSF, or biopsy material. And they may be molecular, genomic, or cellular. We can also look at clinical or imaging markers. Biobanks are the ideal hub to collect specimen and longitudinal data. And again, the initiatives that we see in the NBIA fields are very good with regards to these biobanks. The fourth challenge is that we need good clinical outcome measures, which are measurable changes in health, function, or quality in life that result from our treatment intervention. And we could consider using functional outcome measures, for example, how good a patient can do a walking test. We can also do imaging markers, for example, the iron accumulation in the brain, or look at changes of blood markers or gene expression. We do have to be aware that some of these outcome measures may not be specific enough to determine treatment effects, so we have to validate these. In recent years, patient-centered and patient-reported outcome measures have drawn a lot of attention because they are grounded in what matters most to patients. In fact, there is also a patient-centered outcomes research institute, and they have a rare disease advisory panel. There are different categories and examples of patient-reported outcome measures listed here. So the categories include assessment of disease burden and level of unmet needs. You could assess treatment impact, patient perception of change, or the meaningfulness of perceived change. And there are various examples of these patient-reported outcome measures on the right. You can also use different instruments to measure these patient-reported outcome measures. So they may be rare disease specific, in that they have been developed for a particular rare disease and then used in a trial for that disease. An example would be the scale of assessment, the scale to assess the activities of daily living in PCAN, or the clinical rating scale in PCAN, which you will all be familiar with. You can also use a non-rare disease specific scale, which has been developed for a disease that is not the rare disease you're looking at, but is then used in your rare disease clinical trial. For example, the UPDRS, which was used in the deferiprone trial for PCAN. And then there are also generic or study-specific rating scales. So I think what we need to do in the future is to identify and characterize our biomarkers and outcome measures which may be suitable for an MPAN trial. And we need to develop the MPAN specific rating scales, and it's exciting that Marta is doing that at the moment. So I look forward for this to be published once she has validated it so it can be used in a broader group of patients. The fifth challenge is that we need solid knowledge of the disease. This includes that we can estimate the magnitude of the problem, determine the underlying incidence and prevalence rate, and this has an asterisk because this is important when applying to the regulatory bodies later on. We need knowledge of the range of disease manifestations. So what's the clinical variability? Again, we've heard about that in earlier talks, that there is in fact a broad clinical variability in MPAN, but also in the other NBIA disorders. We need knowledge on genotype-phenotype correlations. Again, I was excited to see this during the meeting. We heard about this in MPAN on the first day. We also heard about this today by Susanne Hayflick when she showed her genotype correlations. We also need solid data about disease progression over time, so natural history, and I spoke about that earlier. And we need to identify the stages of the disease progression that may be responsive to treatment. So should our future treatment be given in the mid stage of the disease? Will it also be helpful in late stages of the disease, or will it then be too late for treatment? Or is it something that we could give in early stages or even pre-manifest stages to prevent the onset? I've already talked about the importance of natural history, and that is because this will allow us to use certain clinical trial designs, and because the regulatory bodies request solid data. I've shown you this guideline already by the FDA as to how to perform a solid natural history study. And I mentioned the current paper, the most recent paper from this Chinese group about the natural history in MPAN and our own data as well. So again, I think we need to perform a solid natural history study in MPAN. We also need effective recruitment strategies, and that includes various aspects. That includes that we need to be able to identify our patients. This can be done by enhancing clinical expertise so that clinicians will recognize the condition early. They also need access to provide genetic testing. And it's interesting that in other genetic diseases, there's new initiatives, and I want to share this with you, the Ph.D. Generation Initiative, which is being offered to patients with Parkinson's disease who can now be tested free of costs and receive free counseling in various centers across the United States as part of the Ph.D. Generation Initiative. It's also interesting to see that there are now strategic partnerships between pharmaceutical industry and diagnostic companies in order to facilitate recruitment for future clinical trials, given that future clinical trials will be based or will allow patient inclusion based on their molecular phenotype. Effective recruitment strategies also includes that we raise awareness and that we treasure the value of our rare disease communities. The rare disease communities, which consist of patients and their families, the advocacy groups, the networks, the registries, and the small number of therapeutic area experts. So basically all the people that are here today, and I think the NBIA community is really one of the best examples as to how the rare disease community can be very efficient. Raising awareness can never be done enough, and other rare disease groups have been publishing about this. For example, Lewington and colleagues discuss the why and how to raise awareness and who should be the target audience. Effective recruitment strategies furthermore includes that we build solid clinical research infrastructures with clinical centers of expertise, where we train a study team and create resources to support their trial readiness. And then finally, effective recruitment strategy also includes patient participation itself. And it's interesting to see what drives patients or what motivates patients to participate in clinical studies. And here's a paper about their decision-making when it comes to contributing to a biobank, and how important the patient-recruiter relationship is in this regard. There's another paper from the Parkinson's field I would like to share with you, where the authors asked patients and their caregivers to name the 5 most important reasons why they may not take part in a clinical trial, or to list the barriers to an effective clinical trial. And you can see the answers on the left. And this includes that patients are worried about potential side effects, about the disruption to their current medication, that they may be given a placebo, that there is upheaval to their life when taking part in a trial, that they wish to be kept fully informed, and that they're worried that participating in one trial may exclude them from taking part in another. So I think it is important that we bring our patients and their families to the table early on in the development of the life cycle of drug development, so that we consider these issues and address these. The next challenge is that we need to choose a suitable trial design. And this is because standard trial designs are not ideal to obtain adequate safety and efficacy data when the cohort study is small. So we have to consider alternative designs without compromising the validity or power of the trial. There are various research models available now that can be utilized in small cohorts, so for rare disease research, and you can find a list here. And the selection of the design eventually depends on the choice of controls that you can use, the choice of the outcome, and the nature of the disorder. But clearly this choice should be driven by the defined study question and nothing else. There are various options with regard to the controls. You can either go with no controls, and that applies to diseases where you have a devastating prognosis in the absence of treatment. Or you can use historic controls, where you have a small or rare disease population, where the natural history and the outcome without treatment is well known. And I think this is the option that applies to the NBIA field. We have a rare disease, but we need solid natural history data information. And that is why, again, I've talked about this again and again, why we need solid natural history data. Eventually, you can also use longitudinal outcome measures, which include repeated observation of a few variables, and ultimately this requires the smallest sample size. If you want to learn more about the recommendations for designs of small population clinical trials, you'll find information online, including this paper here. With regards to the analysis of data, this is also very complex, so you need an expert team of statisticians. There is the increasing that people share their data and stop keeping their data silos. And we need efficient data sharing ecosystems for this, or making data public, of course, protecting the health information of the individual patient. This is also because multiple analysis and reanalysis of data in the future may lead to new results and new conclusions. The 8th challenge is that there are various regulatory aspects on the way, because the regulatory bodies have high standards for the sponsor to demonstrate effectiveness and safety. You're all familiar with the regulatory bodies, which include the FDA in America and the EMA, the European Medicines Agency in Europe, there's also a global architecture called the ICMRA, the International Coalition of Medicines Regulatory Authorities, which provides this global architecture to support enhanced communication and information sharing between their members. The EMA itself also has a sub-team for the study of orphan drugs, which reviews the applications that seek orphan drug designation. The formal designation criteria of orphan drugs are listed in the regulations mentioned on the lower right, so in the EMA and the FDA regulation. And basically, this applies to conditions which are rare, so they affect less than 5 and 10,000 people based on the prevalence criterion, and the fact that there exists no satisfactory treatment, and that the new drug, so the drug that is being studied, may produce significant benefit over those which currently exist. To facilitate the development of new drugs, these regulatory bodies have various incentives, and that includes protocol assistance to maximize the chance of success, where you have a closer communication with these regulatory bodies. They allow access to the centralized authorization procedure so that you don't need to apply in multiple times from all the various member states, but you can apply to only one regulatory bodies, which result in a single opinion and a single decision, which will then be valid in all EU member states. The orphan incentives also include market exclusivity and regulatory flexibility, which I'll come to in a second, as well as fee reductions. The regulatory flexibility has these different points. So for example, there's fast track designation, which is meant to accelerate the review of drugs which can treat serious conditions. And serious is defined by the fact that the condition has an impact on survival, day-to-day functioning, or the likelihood that the condition will progress if left untreated. And the examples given on the FDA website are HIV-associated AIDS, Alzheimer's disease, or epilepsy. So I would believe that NBIA would also fall into this category. Another flexibility measure is the breakthrough therapy, which applies to drugs which may demonstrate substantial improvement over available therapies. And substantial is defined by the magnitude of the treatment effect, in that a drug should show a clear advantage over the available therapy. And the other instruments are accelerated approval and priority review. The ninth challenge is that we need funding for all this. Not only does drug development take very long, so it takes 13 years for a drug to develop for neurodegenerative disorders, but it is also very expensive. And it has been estimated that the development of a drug for neurodegenerative disease costs more than $5 billion US. I am, in fact, intrigued by the fact that this is higher by the factor 7 compared to the development of a cancer drug, and I cannot answer as to why that may be the case. However, I do understand that sponsors therefore have to perform a economic evaluation before they move into the developmental field, where they consider cost and effectiveness in that how much does it cost them to produce this drug in comparison to how effective it will be for them. This is why hundreds of thousands of potential drugs die on the way. And there is the term called the valley of death, which is the gap between the academic and the clinical research side, where the drugs die in the valley of death because of lack of funding. We are all familiar with the traditional sources of funding, including the Horizon Europe program by the EU, as well as the grants by the FDA and the other international instruments. We are also very grateful for other sources of funding, including patient organizations and private donors. But it is interesting to see that there are also new funding instruments which the medical and basic scientists may not be aware of, and that includes mega funds and crowdfunding. And this is there are also industries who publish this as to where you can find where you can find this new sort of funding. The idea is that you de-risk the drug discovery process for the small and medium-sized enterprises so that even startup companies can go into this process. So I want to say, let's get ready for a successful MPAN clinical trial. We can find recommendations for small population clinical trials online, not only by the academian side, but also by the industry side. And the paper on the lower left was published by McKinsey and Company, who also look into this because this is really important for society. And we can also learn from the failures from previous studies, and there are reasons as to why these trials failed, and we should consider this when planning our future clinical trial. So the future steps, I believe, that we should keep in focus is that we do a landscape assessment as to what we need in the future and where we should put our priorities for future research. We can then develop a program and then execute a program so that our runner will overcome all the obstacles on the way and then reach the finish line, and that we will have a drug available for our patients in the very near future. Thank you.
Thank you so much for the recorded presentation. I hope we can all see the need for an MPAN intervention trial as something that we're all responsible for at some level.
Oh, it will happen, I'm sure.
Yeah. We have about 1 minute of time left. Are there any other questions from the audience members? Well, if not, thank you, Susanne and Marta, so much for your presentations. You leave us with a significant optimism that progress is being made. And I think that needs to be kept in mind by everybody. We certainly look forward to hearing from both of you at the next meeting in a couple of years and see what further progress is made by the time.
Thank you for inviting us. And all the best.
Thank you. Bye-bye.
Bye-bye.